So I'm Dr. Amit. I'm one of the interventional cardiologists based here at Macquarie University Hospital in Sydney, which is a private hospital. So we thought for today's presentation, we should have some learning objectives. These are some of the key features that I recognized that from this presentation you should gain. Things like recognize clinical features of aortic stenosis, understand the indications for transcatheter aortic valve implantation, and I put in some slides to describe the procedure. We should identify potential complications associated with a TAVI procedure, and then at the end of it, try to apply the knowledge to a clinical case. So I'll just start with the case presentation. This is actually the case we did yesterday. So he's a 82-year-old gentleman. He came in with a NYHA class 3 symptoms of dyspnea over the last 6 to 12 months, gradually worsening. He had significant medical comorbidities. He has chronic kidney disease. He's on twice-a-week hemodialysis, type 2 diabetes, atrial fibrillation. He has a permanent pacemaker for a previous significant AB conduction disease, hypertension, and hyperlipidemia. So I'll play some echo images for him. So on the left side, there's the parasternal long axis view. And you can appreciate the aortic valve there. And it's a close-up of the aortic valve. So you can see it's quite a calcified aortic valve, which is opening, but minimally. The LV function looks normal on the echo. Then there's a short axis view of the aortic valve where we can further appreciate the calcified leaflets. And then there's a 3-chamber view where you can again see the aortic valve is quite thickened. There's very minimal regurgitation there. When we do the continuous wave Dopplers across the aortic valve to assess the numbers, so you can see that there's a Vmax of 3.1, a mean gradient of 23, a valve area of 0.7, index aortic valve area of 0.3. So in terms of definition of severe aortic stenosis, I would like it to be an interactive presentation. So in terms of definition-wise, looking at these numbers, what would you call this aortic stenosis as? If anybody wants to give it a go. Or
The
maybe
severe aortic stenosis.
Sorry?
Severe aortic stenosis. The area is less than 1 centimeter.
Based on the valve area?
Yeah, and the mean gradient.
Well, the mean gradient is actually not in the severe range. So by definition, severe aortic stenosis, you should have a valve area of less than 1, Vmax of more than 4, mean gradient of more than 40. So in this particular case, you can see the valve area is in the severe range, but the other numbers, they do not fall into the severe category. So these conditions are what we call sometimes the paradoxical low flow, low gradient aortic stenosis, because you have a valve area, you have one criteria which is in the severe range, but the other numbers are not falling into the severe category. A classic AS will have the numbers that I said by definition should be severe AS. But when somebody's ejection fraction is normal, which in this guy it's normal, but you have a valve area which looks like severe, but you're not getting severe gradients, then that is what we call paradoxical low flow, low gradient aortic stenosis. And the low flow, so that's the definition of a paradoxical low flow AS, where you have a valve area of less than 1, a mean gradient is less than 40, LV function is preserved, it's more than 50%, but the stroke volume index to the body surface area is less than 35. So the LV is not generating an enough stroke volume to generate those kind of gradients which we should see in severe AS. So these are called the low flow states. Now, the issue with these patients is that they can sometimes be diagnosed as moderate aortic stenosis based on this, because they are not fulfilling the clinical criteria for severe AS. So some people may just treat them as moderate AS and continue to follow them every 6 monthly. Now, the key mechanism where these patients have low flow is because they have a small hypertrophied left ventricle. Because of the hypertrophy of the left ventricle, the filling of the ventricle is not is not perfect. And because of that, the stroke volume that this ventricle is generating is low. And that's why it's called a low flow state. And the common causes for having this low flow state is just age related, because with age, they can have diastolic dysfunction, hypertrophy. They can have a small LV cavity just purely because of the age or the anatomy. And long-standing hypertension can cause LV hypertrophy and diastolic dysfunction, because of which the LV filling is not adequate. And so the stroke volume is not adequate. And so you do not see very classic high gradients in this AS. So how do you basically then decide whether this patient has severe AS or whether it is moderate AS? Because it can be either. They can still be moderate aortic stenosis, but they can be severe aortic stenosis as well. So the key thing there is to differentiate whether it is severe aortic stenosis, because if it is severe AS, then that will need intervention with valve replacement. And if it is moderate, then you can just continue to monitor them. So in this paradoxical low flow state, one of the tools that we use to decide whether this is severe is based on the CT TAVI, where we do something called a Agatston score on the aortic valve. And by definition, if the Agatston score, which is the calcium score of the aortic valve, if in the males, if it's more than 2000, then that by definition is true severe aortic stenosis. And for females, if that score is more than 1200, then that is true severe aortic stenosis. Below this, we treat these conditions as moderate aortic stenosis, and those do not need intervention, and they can just be monitored. So this patient had an Agatston score of 2,300. So by definition, he was severe AS. And then we discussed it in a heart team meeting, which each TAVI candidate has to go through a heart team meeting, which is a combination of interventional cardiologist, cardiac surgeon, structural heart coordinator. We have the cardiac anesthetist, geriatrician. So we discuss the case, we go through the images, through the CT pictures. And so in this case, why not a surgical intervention? One, because of the age. He's an increased surgical risk. He's a chronic dialysis patient. His anatomy on the CT was suitable for a transcatheter valve intervention. He had good femoral vascular access, so the decision was to proceed with TAVI. So I've just put in some TAVI images for this patient's assessment. So what we assess for a case is, one is we do the annular measurements of the aortic valve, and what we are trying to do there is, so that's the annulus. So annulus is, it's an imaginary line where we feel that all the three cusps are at the same level, the non-right and left coronary cusp, and that's where they end, and that's the annulus of the aortic valve. So we measure the aortic valve annulus in terms of what the diameters are, and from that we calculate the perimeter and the area of the annulus, because that's how the valve sizing is done. Then we measure the sinuses, because the diameter of the sinuses also decides as to what kind of valve we want to use. What are there any risk of blocking of the sinuses when we implant the valve? Because if the sinuses are too small, then you can cause a sinus sequestration by putting in a new valve. So you don't want that. We are also assessing for whether there's any significant calcified nodule in the annulus or extending below the annulus into the LVOT, but that's the LVOT view. The LVOT looks quite clean. There's a very small nodule there at the annulus, but that's not very significant. And then the sinotubular junction also to look for any calcification deposits at the STJ, because some of the valves that we deploy, they reach the sinotubular junction, and if you're pushing against the calcium, you can cause aortic rupture. So you don't want that as well. Then the other thing we look for is the coronary heights and the sinus heights. So that imaginary line that you see there is the, what we assume is the annulus, where all the cusps meet at the same point. And that's done through a special software on the CT called 3Mensio. That's what we use. And so based on that annulus, we measure what is the height of the left and the right coronary height from the annulus, because usually a height which is 11 millimeters and more is safe to do a TAVI. We have done TAVI with lower coronary heights as well, where we need to change our strategy a bit. But usually something below 8 or 7 millimeters, they are the difficult cases, because they are at high risk of coronary obstruction, in which case then you have to use special techniques to protect the coronaries when we do a TAVI. Or sometimes you may not be able to do it and you may have to send them for surgery. the same software then we use to assess for the, yeah, it's the same software we assess to use for what we call the aortic angle. So the aortic angle is what we define as, so we, with the annulus, which, so we take the line across the annulus and then we measure the horizontal angle of the aorta to it. Now, anything above 45 degrees and all is considered a horizontal aorta. And horizontal aortas are always difficult cases because there, when you try to implant the TAVI valve, then the positioning is always very difficult compared to a more vertical aorta. Now, this guy's angle was 62, so that is by definition quite a horizontal aorta. So it was a challenging case. Then we look at the iliofemoral axis to see whether there's any significance. So that's at the level of the common femoral artery, then at the external iliac and the right iliac artery. And because we're going to access the common femoral artery, we need to make sure that there's no significant anterior or posterior calcium on the wall, because if you want to puncture at a site, that should be clean, because if there's a lot of calcium, then closing that vessel at the end of the case, when you're using such thick sheets to enter the vessel, that's a nightmare, and sometimes that can fail, and then that poses the risk of high vascular complications. So here the femoral axis on the right side looks quite clean. Actually, the axis on the left side also looks fine. There's a bit of tortuosity of the vessels, as you can see, so they're not very straightforward vessels. Then we have based on all the endless measurements that we've done, then we have the valve sizing chart that we use. Now, this particular case, we used a self-expanding Medtronic valve. So there we decide the size based on the perimeter. When we use the balloon expandable valve, which is the SAPIEN valve, there we decide based on the area of the annulus. And other things we consider is what are the sinus of Valsalva diameters, because they should have the acceptable. So like most of the times, if they are more than 25 millimeters of diameter, then they are quite safe to go with these. So this guy had a perimeter of 85 millimeters and a Valsalva diameter of 36.4. So it fell into the 34 category of the evolute valve. So that's how we kind of choose. So when we do the CT analysis, this is what the final chart we get. So on the top, you can see the minimum maximum diameter, the mean diameter of the annulus, perimeter, area, LVOT dimensions, then the diameters of the femoral arteries on the right and the left, sinus of Valsalva diameter, sinus of Valsalva height, and coronary heights. So coronary heights here, the left coronary height is 16, right is 20. So that's well within acceptable limits. Sinus of Valsalva are quite wide. That was the analysis. This is how the evolute valve looks like. This is self-expanding valve. This is the basic structure of the valve. It's a nitinol frame, which is a self-expanding frame, and this is the porcine tissue valve. The good thing about the evolute valve is that these are supraannular valves. So basically, if your annulus is there, your native aortic valve leaflets are positioned there, and those are the stenosed ones. But when you implant this valve, the leaflets of this valve are up there. So it's a supraannular, not an annular valve. So that's why the overall gradients with this valve at the end of the case are better, because you are basically making a totally new annulus there, rather than trying to expand the original annulus there. Okay, so that's the thing with the supraannular valve. So these are the basic measurements. That's the annulus, the point measured as A. That's the annular measurement. That's the sinus of Valsalva there, sinus heights, and that's the valve frame height, which is usually around 45 millimeter for the evolute valve. This is the balloon expandable system, which is the Edward Sapien. So that's a shorter frame of the valve. It's made of bovine leaflets. Now, these are all the stuff which comes with the Sapien valve. So there's a crimper which is used to prepare the valve, so that the medical rep does it. The valve comes with the balloon, because it's a balloon expandable valve. So it's got its internal balloon. That's the inflator for the balloon for the valve, and that's the sheath which comes with the system. So that's the E sheath called the commander system. There's the E sheath, and then the delivery system is called the commander system for this. So this valve has two skirts. Now the previous valve that had one outside skirt. So this has one inner skirt of the valve and an outer skirt of the valve. The purpose of the skirt is that to seal the annulus more efficiently, so that you don't have any paravalvular leak when you deploy the valve. So having this double skirt helps with reducing the chance of having a PVL, which also you don't want in TAVI cases. And that's the commander system for the delivery of this kind of valve. It has various knobs which we use to control, to position the valve. It's got a flex wheel where when we kind of are crossing the arch of the aorta, we use this flex wheel to give a bit of flex to go around the aorta more efficiently. And this system can be used in various cases where sometimes where you have uh, things like, so there was a case we had done where the patient had a previous coarctation of aorta done. So there was a stent there from the coarctation of aorta. So in which case this device is quite useful because the flex wheel helps to maneuver it through the aorta quite well rather than using the other system. So when we talk about the valve choice, deciding in a TAVI case whether we use a self-expanding or a balloon expandable valve, what are some factors that we use to decide as to which valve we use? In many cases, both valves can be used, so it's very operator dependent as to what they are comfortable using. Certain scenarios you favor one over the other. So like when you know that the anatomy is such like where you may need to reposition the valve a few times, if you're not happy with the position, then you favor using a self-expanding valve. And I'll explain that later because why we use there, because the self-expanding valve can be recaptured a few times. The balloon expandable valve is once you inflate it, then it's there. You can't really do anything about it then. Either it stays there or it flies out. Okay, so you can't do that with the balloon expandable valve, but self-expanding, you can recapture it at least 3 times. If there's a concern for annular rupture, which is cases like when there's a lot of calcium extending below the annulus into the LVOT, or there's sinotubular junction calcium, then you want to use a self-expanding valve because the self-expanding valve, it expands by itself and then it stops. So it's not pushing against the calcium with the force compared to a balloon expandable valve where you inflate a balloon to deploy the valve, because there the balloon expandable valves, they have a very high radial force. So when you expand the balloon, you can push against a chunk of calcium and that can cause an annular rupture, and then the patient have a cardiac arrest on table. Then if the coronary heights are like optimal, then you can use a self-expanding valve. If the heights are a bit low, then many operators prefer the balloon expandable because, as I showed you, it's a short frame valve, so you can put it below the coronary height even if the heights are low. But the self-expanding valve, it's got a tall frame, so you don't want to be interfering with the coronaries there. Horizontal aorta depends. Like it can be difficult to place a self-expanding valve in the horizontal aorta, but because it is repositionable, I prefer using it in a horizontal aorta. But if it is a very horizontal aorta, then it can be difficult to put a self-expanding also. So there was a case I did which had an angle of 90 degrees, and there I used a balloon expandable valve with a very good result. So it all depends on the day what we choose, or depends on a mood as well. So I made a video of, so that's the femoral access that we take, ultrasound guided access. So because you're putting in a sheath, which is almost like, so depending on what size valve you're using, the sheaths can be from uh, 14 French to 18 French, sometimes to 22 French sheaths. So 1 French is around 0.33 millimeters. So you're creating a very big hole in the artery. So your femoral access is your main thing for your procedure to go smoothly. So you can see the femoral artery there, and you can see the needle coming down there, and then you puncture the femoral artery to get a clean access. And and you want to position it at a place where you have the femoral head below, because that's how you apply compression later, because you want to compress against a bone. You can't compress against soft tissue. So that's why you use the ultrasound. And then once we've taken access, then we take a picture of the axis to see where we punctured. So you can see the entry site is there, is on the femoral head, and you have to be above the bifurcation of the femoral artery. So the bifurcation is down there, you can see. So that's why that's a good clean puncture for the axis. Then we do something called pre-close, which is the pro style system. So we put internal sutures prior to the case. We don't tighten the sutures, but that's why it's called a pre-close system. And the device is called the Pro Style. So these are internal sutures that we apply to the vessel. So once we've taken access, So we go in with this device with the Pro style, and we enter the vessel. When we enter the vessel, you'll see the blood flow out from there. It has to be a clear spurt of blood. Like now you see that. So there's the femoral artery flow there. Once you're there, then you kind of deploy the paddle, you release the sutures inside. And so we use basically two Pro styles at like a 10 and 2 o'clock position in the artery. And we leave them undeployed, like untightened there. So because we tighten them at the end of the case. Okay, so that's first one, and then we kind of deploy the second one. And all the time you have to make sure that you have a wire access in because you don't want to lose that. Otherwise you lose the entire access. And it's always a two operator case, TAVIs, because as you can see, that's my second operator who's doing the other maneuvers like walking the device over the wire out. So you need to have two operators for this compared to a miter clip case where you can do like a single operator can do it. I think the same. Okay, so then the next thing is what we call CT planning for a cusp overlap view. Now, this is an important thing to understand that so with the three cusps, the non-coronary cusp obviously is where there's no coronary artery coming out. And the non-coronary cusp, that's why appears a bit lower compared to the right and lower coronary cusps. Now, what over the last few years we have come up with something called the cusp overlap technique. So where what we try to do is that we want to overlap the left and right cusp on one side and the non-coronary cusp on one side, and we want them in the same plane, so that when we deploy the valve, because we are deploying the valve based on where the non-coronary cusp is, so we want them at the same level, so that we don't end up deploying the valve too deep, because the risk with that is that below the non-coronary cusps runs your membranous septum where the conduction system is, and that will cause a heart block. And then the patient will end up needing a pacemaker. In this case, it wasn't a concern because he already had a pacemaker in. But if somebody does not have a pacemaker, then we try to use the cusp overlap technique. So with this, that also can be done with the CT analysis. So there you basically put the non-coronary cusp on one side, and then you overlap the left and right coronary cusp on one side, and the angle that you get will be your cusp overlap view, which will be your working angle while doing the TAVI, which you can see on the right side. So that the RAO 13 and caudal 42 is your cusp overlap view, which will be the working angle. And that's kind of depicts the same thing, that the two cusps are overlapped there, and then the right and the non is non can be isolated from the two, and the pigtail during the case that stays in the non-coronary cusp because that remains a landmark for the case. So on the CT, when we've decided what angles are there for the cusp overlap view, when we're doing the case, we take a picture in that particular angle to see whether that's a true. So if you can see there, when you took the picture, so that's a non-coronary cusp. You can see one cusp there, you can't see the other. That means they are like perfectly overlapped. So that's like a cusp overlap view, and they're like aligned well. So that angle calculated by the CT was quite good. Sometimes when the CT calculates the angle, that may not be perfect. So there we have to make some adjustments and take a picture which is a perfect cusp overlap view, right? Because we don't always go blindly by the CT angle. So next step is, once you've had the cusp overlap view, then you have the pigtail in your non-coronary cusp, then you come up with a catheter to the aortic root, and then you cross the valve with a straight wire. Okay, so that's a straight wire, so that you have crossed the stenotic valve and your wire is in the LV now. And over the wire, you bring in the catheter and you enter into the LV. And once you're in the LV, then you put in a pigtail, because the pigtail obviously is a curled catheter, so that's safe. You put the pigtail in there, and then over the pigtail, you bring in your working wire, which is the stiff wire that you will use for the TAVI implant. And we have different kinds of stiff wires. Yesterday, for this particular case, we use what we call the Confida wire, which is quite stiff. Above this, the stiffest one is called the Lundquist wire. Now, because we were planning to use the Evolute 34 valve, which is a bulky valve, and that deployment can be very unstable. That's why I chose to use this stiff wire. Normally, we would use a Safari wire, which is a standard wire to use. So once the wire is in, then you do a pre-dilatation. So that's a balloon. So we're pre-dilating the valve. there. The balloon size we decide based on the CT analysis, depending on what the minimum and maximum diameter of the annulus is. So we kind of choose a balloon which is intermediate size, and we give a gentle pre-dilatation. The reason for that being that once the valve goes in, so that the valve expands well, because you don't want an under-expanded valve. So that's why with the balloon, it kind of opens the valve a bit well, prepares the valve for the prosthetic valve to go in. So next thing, before we take in the actual device in, we do what we call a fluoro check, which is, so this is the prepared valve. So the valve is inside in this device, that's the capsule. That's the lower end of the valve, because that valve will come in like this. So that's the inflow of the valve, that's the outflow of the valve once it sits. So we do a fluoro check to see whether the valve has been prepared well, because sometimes the valve is not prepared well. You may have to prepare a new valve. Now, what we are trying to look for in this fluoro check is in the next slide. So that is the inflow of the valve, that is the outflow of the valve. So what you're trying to see that in the inflow, there's no crown overlap. So when we say crown overlap, that means, so that's the inflow crown there. So we usually look at this. So you see this shadow there. So that shadow should not extend below the fourth node there. So these are the nodes on the valve. So if it extends beyond the fourth node, that means it's not a properly prepared valve. So then you need a new valve. Secondly, on the outflow side, you need to make sure that all these struts are parallel. If you see the right picture, you can see there's a bit of a mishap there. So that's not a properly prepared valve. And then you have to look for any bends or curves in the capsule as well. Okay, so that's what you are trying to check for in the fluoro check. So next came in the initial deployment of the valve. So as I said, that this was a horizontal aorta, and I prefer to use the repositional valve, and I'll tell you why. So when we were doing so in this self-expanding valve, so this valve you can open up to around 80%. So you can come and stop there. That's the 80% deployment. And then if you're not happy, you can recapture it. You can recapture it and then reposition it. Okay. So, but compared to the balloon expandable valve, once you inflate the balloon, that's it, you're done. You can't reposition or anything. So here at the 80% mark, when we kind of stopped, so the depth here initially looked okay. And so when we say the depth of the valve, what we are trying to see is, you see these small tiny dots at the base of the valve. So those are markers at a 3 millimeter distance. Okay, so what 3 millimeter from the base of the valve. So what your aim of the depth has to be around 3 to 5 millimeter from this pigtail base. Okay, so this marker, as long as it's around between 3 to 5 from the base, that's like a good depth. You don't want anything deeper than that. So when we did an 80% deployment and then we took another picture, now if you look at this one, so we haven't still released the valve, but you see that 3 millimeter marker is there, but then there's a long gap there. So this valve kind of jumped in a bit. Okay, so here in this picture, it's almost like 6 to 7 millimeter deep, which is not an acceptable position. So then we had to recapture this again. And so then we recapture it and then we started repositioning. So now you can see the 3 millimeter mark are right there at the pigtail, so which kind of looks like a good position till now. And so this time the valve was remaining quite stable there. So we ended up deploying it, and then that was the final position of the valve, which actually is very good. If you see the dots there, so it's almost like 4 millimeter or something. So which is an ideal placement for this valve. Okay. And then we took a final picture to see whether there's any paravalvular leak, but you see that you can't actually see any leak around the valve, and the position is good and the valve looks very stable. Okay. And finally, when everything is out, then we take what we call a digital subtraction angiogram, which kind of blurs out your bony tissue from the behind, because what you want to see is that if the vessels are okay, because we've done the closure and everything, we close the proglides and then we take a final picture of the vessel to see the flow is good, and you see that everything looks fine. So that's the case is kind of successfully done. Now, complications associated with TAVI, usually most common are vascular, that is bleeding from the access site. So most of the time when you have deployed the two proglides, then if it's still bleeding, then you can deploy another one. and you can try something called an angioseal, which is a collagen-based closure device. If everything fails, then sometimes you have to call in the vascular surgeon to come and fix it, and then they may come and do like a covered stent, because if the vessel is bleeding too much, then you have to do something about it. Stroke or TI is less than 5% of a risk. Like when you're fiddling with the calcified valve, now if you routinely do a CT or an MRI of such patient, you will always see microthrombi in the brain anyway, because something goes to the brain at such. But having a major stroke from a TAVI is less than 5%. If some patients have had a previous history of a stroke, then in those cases we use what we call a sentinel device, which is like a basket. We put two baskets in the right and the left carotid to protect anything going up to the brain. So that we use only if there's a history there. Other complications is the conduction block, as I said, complete heart block, which can happen if the valve is deployed too deep. Sometimes the patient has a preceding right bundle branch block prior to the case, then the chances of having uh, heart blocks is higher. So those patients, we are very particular about what kind of valve we use. So in those cases, I prefer using a sapien valve, because these uh, self-expanding valves can go deep and they can cause a complete heart block. So valve-related complications, paravalvular leak, as we said, valve embolization, uh, depending on what the mechanism for that is. Paravalvular leak, if there is some mild, moderate paravalvular leak at the end of the case, then we take in another balloon and expand the valve a bit to kind of get rid of the leak. And most of the time that is successful. If the valve has been deployed too deep, then the issue with that is if you deploy the valve too deep, that means the skirt of the valve has kind of gone too deep. So the paravalvular leak is because you've deployed it too deep, and the skirt, which is supposed to seal the leak, is already deep. So you can't really do anything in that case. There, what you have to do is then you have to put in a new valve at a higher position. So you have to put a second valve in at the same time. Cardiac tamponade. This you will recognize very early in the case. Steps where you can have the cardiac tamponade is one when you cross the valve with the straight wire. So that straight wire, sometimes if you push it too deep, it can perforate the LV and you can have a tamponade. And so if during the case, if your blood pressure suddenly drops, the first thing you want to see is whether there's any pericardial effusion developing there. Okay. And if there is, then you need to kind of do a pericardiocentesis on the thing. Another reason for pericardial tamponade obviously is aortic root rupture. So if you've ruptured the aortic root, then you'll have a tamponade and patient will collapse. So that other things, acute kidney injury, well, that's contrast related. Uh, Death less than 2%. Like we've actually not had any death on table for a TAVI patient. So I think that's about it with the case. So I'm happy to take any questions if there are.
Thank you so much, doctor. I want to know your opinion on TAV and TAV procedures.
Yeah. What about it?
The success rates.
Success rates are pretty
Is
good. So the thing is, so if it's a, so you're talking about a TAV in TAV or TAV in SAV. So like if the patient has had a surgical aortic valve previously, then obviously the patient has had a previous sternotomy, and they are obviously not always good candidates for a redo surgery. So in those cases, TAV and SAV, that's a good option. But their assessment is a bit more complicated because they are at higher risk of having coronary obstruction because when you're putting a new valve inside a bioprosthetic valve, then you're pushing the leaflets of that bioprosthetic valve outwards, which can obstruct the coronary. So when you do the CT assessment in those cases, you do special measurements called the virtual to coronary distance. So like the distance between the virtual and the coronary artery to see whether they are within permissible limits. And if they are not within permissible limits and they are at a risk of having a coronary obstruction with the case, then you do leaflet modification procedure like basilica, where you basically lacerate the leaflet of the bioprosthetic valve and then do a TAVI. So that's doable. So, and TAV in TAV is also a very viable option. So we have done a lot of TAV in TAVs with a very good success rate.
Thank you.
Any other questions?
Does anyone have any questions? Okay, Muhammad.
Yeah.
Okay, first, thank you, Dr. Amit, for the great explanation and the session. Um, I have a question that because I'm interested in emerging biomaterials for aortic valve reconstruction, such as, for example, tissue engineered leaflets. Um, do you think, on a long term, that these technologies, such as next generation biomaterials, will become an great alternative for the transcatheter aortic valve implantation, especially for younger patients with aortic stenosis?
Mhm. So what materials are you talking about?
The next generation biomaterials, for example, such as tissue engineered heart valves or decellularized biomaterial scaffolds or advanced polymers valves.
Yes, I think that has a great scope because I don't know if you know, because one of the valve that has come out, which is not yet commercially available in Australia, is called the Resilia valve. That's part of the Edward Sapien balloon expandable valve. So where the leaflets they have been made from the specialized material, that the degradation of those tissues and the wear and tear of those tissue valves is considered to be much lower compared to the standard Sapien valves. So those we use those valves in Canada for some cases because it like initially came out only last year or so, so it's not yet available in Australia. But apparently, the average lifespan for normal bioprosthetic TAVI valve at the moment is, they say, around 10 years or so. But with this Resilia valve, which is made of this special polymer tissue, they say the life is close to around 15 years or so, 15 to 20. So, but that will have to be seen because the valve came out only last year. But yes, there's a big scope of such material.
Yeah, that was great. Thank you.